Yes. As you may have read from his bio, he is a physician who trained at the University of, I don't know how to say this, Ibadan in Nigeria, who worked as a civilian medical officer at the Nigeria Police Medical Services headquarters, and completed a residency in community medicine with the West African College of Physicians, He's completing a Master's of Public Health program at Emory, and expecting to graduate in the next few months. He has been one of the collaborators with our chair, Dr. Famu Nwariaku, on a large injury capacity building collaboration by the NIH in Nigeria. So go ahead, Dr. Kehinde, please feel free to share your screen and have your camera on and take it away.
Thank you for joining. Thank you for inviting me to this meeting. Can you hear me? Am I audible enough?
Yes, we can hear you. I can hear you just fine.
Fine, thank you. So I have the right to share my screen. Yes.
Yeah, there it is. Perfect.
All right. Thank you. Once again, my name is Kehinde Ogunyemi. I have over 10 years of experience in public health, and I'm so excited to be part of this meeting today. So as you're already aware, this is one of the partnerships to develop injury research capacity in sub-Saharan Africa with a focus on Nigeria and Ethiopia. So this is one of the Dr. Fiamu's NIH grants, and I'm one of those trainees. So one of the things that we are trying to do is to try to understand and characterize the problem of prehospital mistriage amongst other problems. So before I delve into the discussion, I just want to acknowledge my cultural reflexivity. So as you're already aware, I have clinical background. I also have public health background, especially in community medicine. And my professional goals is geared towards research. So I have some biases, in terms of why I'm interested in this research and all that, and I acknowledge them, and I've tried to just manage them as much as possible. And regarding this presentation, so as an overview, as some of you might already be aware about the country, Nigeria, it's the largest country in West Africa. But in terms of road traffic injury bodies, Nigeria, ranks 5th in the world and ranks 1st in Africa. For this study, we're interested in Federal Capital Territory, Abuja. And again, the site has been chosen, the states, not really a state, it's the capital anyway, but it's been chosen because it does lead in terms of road traffic injuries body. And again, that's where we have most of our existing injury research partnerships, being present. So essentially, there are 6 trauma regions in Federal Capital Territory of Nigeria with several designations. The trauma center designations. So the first trauma region is the Abuja Municipal, and that constitutes both a level 1 trauma center and level 3 trauma centers. Again, we also have the Buhari trauma region. In that, we have a level 3 trauma center. We have the Kwali. We also has level 3. We have the Kuje. We have level 3, and Gwagwalada, which contains a level 2 trauma center, and Abuja, which also contains a level 3 trauma centers. So essentially, this is just an overview of what the country looks like in terms of trauma distribution. Yes, so triage or mistriage is just, one of those components, one of those building blocks of the prehospital trauma care system. And I so much like this illustration here because it tries to lay out the different processes that occurs even before we get to the injury scene. So there's an information platform, which is not what research is focused on, but we'll keep that in the loop as well. We have the dispatch center, and we now have the trauma, the prehospital trauma level, whereby the injury occurs from road traffic crash, in this case, the emergency medical services response, there's a transportation that follows, and there's a definitive care that also follows. So this is an overview. So for what we're interested in, we are actually interested in this space, what happens from arrival to the injury scene, and what happens, during transportation of the road traffic crash victims. Again, as a background, what's the public health problem? The public health problem, as we already know, is that there's increasing risk and poor outcomes of road traffic injuries. And unfortunately, there's a disproportionate burden in Africa, like Nigeria. And again, this is, partly driven by limited access to life-saving prehospital trauma care interventions. But in this case, we are interested in looking at prehospital mistriage, which has two components. It has the under-triage, it has the over-triage component. I will explain what all those means, as some of us may already know, in the comment slides. So, but beyond the problem, there are also some barriers, because like I said, it's a system thing. So it doesn't, triage does not operate on its own. It's dependent on so many, so many factors and signals, as the case may be. So essentially, when it comes to the structural barriers, we talk about the trauma system as a whole. The current, reality for my country, Nigeria, is that the trauma system is weak. And unfortunately, the weakest link is actually the prehospital trauma, system. Again, it's not just weak, it's also disconnected. And it's grossly underfunded. Again, there's also one component that I'd like to bring to the discussion, which is the area of the community. Like I said, as a community medicine, I'm always thinking about integration of community into most of my public health interventions. So we also want to be aware that the community has a role to play as bystanders, as people with lived experiences. They have a lot to contribute to this field. But unfortunately, not so much is ongoing in that regard. And we have seen lack of engagement, however, there's been, evidence that shows that they have good participation in terms of bystander assistance in terms when a road crash occurs, but there's no clear definitive platform for engagement between, the definitive care, trauma care, and the community. So it's a barrier. Again, the process barrier, we are interested in the poor first aid and basic life support knowledge and transport decision making. So this is well documented. And this is in part driven by limited trainings, first trainings on the job, and also sort of refresher trainings. There's complete lack of triage protocol. There's complete lack of triage protocol. And there's lack of access to real-time bed availability information, amongst other key information that are critical in terms of prehospital triage and also prehospital trauma care as a whole. Again, the other component that is very important too is the area of the field challenges. Given my work experience, we've seen language barrier, where somebody is not able to understand what the responder is saying or what the bystander is saying, or even the patient themselves is saying. So there's a language barrier. There's a literacy gap. The level of education among the first responders are not equal. Community terrain navigation. So yeah, people are not really familiar with the community where the injury scene has occurred. So these all have, direct, indirect relationship as to what we see in the trauma set in terms of both the presentation and also the outcomes. So this is just a quick overview of that. So regarding this study that we have been doing, this is the current study update. It's going to be piloted in 7 sites in Federal Capital Territory of Nigeria. Then it has two components, like I said. It has both the pre-hospital and the triage and pre-hospital triage. For the pre-hospital and the triage, we are including these 5 hospitals, which are the Wuse General Hospital, the Buhari General Hospital, the Kwali General Hospital, Kuje General Hospital, and Abuja General Hospital. We also have the pre-hospital triage, where we'll be looking at National Hospital Abuja and University of Abuja Teaching Hospital. Then it's an electronically, it's going to be electronic data collection method, and we are using RedCap for this. As you've seen, this is just a snapshot of the survey that myself and Xavier developed. So a shout out to Xavier for helping with that. We were able to make this ready. Then I have the good news that we've been ethically cleared for all the sites, but currently we are recruiting the research assistants, but majorly focusing not just on recruitment, but also focusing on establishing a good partnership and collaboration platform, because we foresee, long-term collaboration, and we want to be able to sustain, to be assured of their commitment to this study, and to also ensure that the commitment is sustained across the study, period. So right now we have been successful with 5 sites, identifying the heads of the emergency department, identifying with the research assistants from those end. We are currently, making efforts and, getting through the other 2 sites. These are, especially dispersed setting. But again, because we want to make our study quite representative, we wanted it to touch all the 6 regions, the 6 trauma regions. But, there are different protocols, there are different policies in each centers. And again, we have been challenged by the problem in the country, which is incessant strike, medical strike, and also even national strike as well. So these have actually delayed the commencement of the project. Again, the ethical approval too, took a while. We didn't anticipate that, but we are making progress. So far, this is where we are. And hopefully we have done the first set of training for the local PI, Dr. Laomi and his team. So once the research assistant team are fully, integrated, then I will conduct the second set of training in terms of the Mistriage questionnaire. So the problem statement again, but now focusing on the components of pre-hospital mistriage. We are actually going to be using 2 triage tools, as the case may be. We have the injury severity score, and we also have the triage revised trauma score, which majority of us are familiar with. And the reason why we are actually using these 2 is because, first of all, the injury severity score, we see this to be more, visible on the field with first responders like police, like federal safety, who actually have minimal, level of medical knowledge. So because, and we think this is good because we all know, some of us know how this is being calculated in terms of how we use the anatomic, body regions to assign scores based on level of severity and choosing the 3 most, severe injured part. So, but we see this as being most visible. But again, we also want to be able to compare this with what operates, in the hospital setting itself. And the trial revised trauma score is actually going to be more of a physiological criteria, a physiological tool, because it does use both the respiratory rate, the blood pressure, and also it uses the Glasgow Coma scale. But this would have been much more, better if we were talking about more of the emergency medical services, which we don't have in Nigeria, or perhaps, let me say we do have, but it's very, very limited. It's only functional in Port Harcourt, and not all part of Port Harcourt, just a few part of Port Harcourt. That's one state in Nigeria, and also in Lagos. So, and the assistance of those are still, very suboptimal. So the best that we have is actually more of the informal, the tier 1 level of prehospital trauma care, which is being manned by lay first responder, including the police, the federal safety, and also the bystander. So we feel injury severity score is one of those, but again, against a gold standard, which is now the triage revised trauma score. This is the reason why we've included these two. And what do we mean by hospital prehospital on the triage? It's just the erroneous transfer of severely injured patient, road trauma patient in this case, to a lower level trauma center. So, and those lower level trauma center, like I said, will be either designation of 3 or 4. You know, again, we also have, we know that there's an acceptable rate for on the triage, according to the American College of Surgeons Committee on Trauma. It's supposed to be less than 5%. And but unfortunately, not so much, you know, not so many countries have been able to even meet this. Studies have shown that even in the high income countries, this ranges from about 4.98% to about 74% in terms of the on the triage rate. And there's complete lack of this knowledge in a resource limited setting like Nigeria. Again, we also don't even know how this, you know, this construct is associated with road trauma mortality. And these are the reasons, one of the reasons why we are conducting this study. On the overtried side, just the complete opposite. There's an erroneous transfer of mildly or moderately injured patient to a high-level trauma center, which can have designation of 1 or 2. Again, the acceptable rate is between 25 to 35%. And like I said, no country has been able to, you know, been close to this acceptable rate. So studies have shown that this has ranged between 30% to as high as 75% as well. Again, there's complete knowledge gap in this baseline rate. And this time around, we are not interested in the mortality, but we are also interested in other disincentives, such as catastrophic expenditure for the patient, and also for the health facility financial loss. Catastrophic expenditure will mean when a patient spends more than 10% of their, you know, monthly income on road trauma care, and facility financial loss will be, you know, the deficits of financial revenues that could have been generated if they've had severely injured patient transported to the center, which is actually been built for in the first instance. So, like I said, you know, there's a mix of the public health concept, the clinical concept, and also the societal concept. So I like to think about this as an holistic problem. And we will use the disease causation analysis. We can try to understand the unmet needs of prehospital trauma care system. You know, this is, we will look at the host, we know who the hosts are. And if we also look at the agents, we know what the agents are. So in this, we have the knowledge skills, we have the practice, we have the infrastructure. And again, we have, you know, the environment itself, which contains the leadership, the policy, the legislation, the funds, training, and all sort of other things. So this is the way we envisioned this project. And that is why one of the baseline studies that we also did in 2018 was on assessing, you know, the knowledge and skills of police officers in terms of first aid. And unfortunately, we found poor knowledge, like I said. Only 5.7% of police officers have good knowledge of first aid application to road trauma patients. Again, as a step further, we also want to also understand the practice, and that is where the issue of the triage or the mistriage came in. So what is going on the field? What's obtainable on the field? So we don't know this yet, and this is what this study envisions to uncover. Then again, we hope to now provide the infrastructure. And an example of such is decision support tools, which I will also make mention of, for amongst other things like surveillance, communication, and, you know, use evidence to drive resource mobilization for equipment as well. So what's the public health benefit of this whole intervention itself? So first of all, it does provide a baseline evidence for us to be able to evaluate future prehospital interventions across research, interventions across advocacy, interventions across effective implementation science. So we want to have that baseline evidence regarding this. Again, because we have been able to combine this prehospital triage tool, we have the opportunity to also determine prehospital triage tool accuracy. We want to be able to demonstrate that the ISS tool, which is a non-physiologic, tool, has good sensitivity or positive predictive value versus the gold standard, which is the revised trauma score, rather. So again, we have the benefit of assessing the prehospital mistriage estimation. What's the difference? The one is it will compare the results with the ISS and also with the revised trauma score as well. So we can understand which one is underestimating, which one is likely to overestimate, and we can be able to, make informed decisions about how these are being measured in daily practice as well. Then again, it does have opportunity for us to have to inform development of decision support tools, like I mentioned earlier. And we are thinking about, how we can use this as a preliminary evidence to apply for NIH K43 grants application to design and test the visibility of a smartphone app-based prehospital triage tool that's going to help the lay first responder, including the police. We're emphasizing that we start with the police community because they have the human resource capacity for this. And again, we can then use them as a prototype for other first responder settings, including the federal safety and perhaps even the bystanders in the future. So this is the future goal that we have for this project. Again, like I said, we are not just building partnership and collaboration with this study sites. We are building it because we want to establish a long-term relationship. And that way we can have opportunity to continue to have long-term researches and as well be able to, monitor the trauma system improvement as a whole. So to do that, we need to be transparent. We need to have respectable, common goals or mutually beneficial common goals. And to do that, it takes a while. So partnership is not a short-term thing, it's a long-term thing. So that's why we're not really, pushing anyone, but we're also trying to ensure that study sites are really, really interested in this study and they are willing to be part of this now and in the future. And we foresee them also being able to use the REDCap database as part of their own, daily surveillance measure for road traffic injuries, so that over time we can monitor the trends in terms of the rates itself and the outcomes. We can also, use it to evaluate the effectiveness of any future interventions going forward. So as a conclusion, I would like to thank the University of Utah, especially Professor Ogunyemi, who gave me the opportunity to be part of this project since 2017, and his team as well, including the University of Utah Center for Global Surgery. To also thank the National Trauma Center, Abuja, with our local PI, Dr. Wale Olaomi, who is the one coordinating this on our behalf. Dr. Wale Olaomi was the former Deputy Chief Medical Director for National Trauma Center Abuja, which is the only level 1 dedicated trauma center in Nigeria. He still currently is the chief trauma surgeon for this center as well. He has much of the experience in research, and I want to thank him for his team, also for being able to put together this study and making it go smoothly as planned. We are also very, very grateful to the study site ethics committee for revalidating this study in this case. Then again, the heads of the emergency department, for accepting to partner with us and work with us, and the research assistants that are going to be collecting this data for us. And we are so most grateful to the first responders themselves, the patients, and perhaps their relatives. Thank you for giving me this opportunity.
Thank you, Dr. Kehinde, for going over your project. I know I have a series of questions. I don't know if anybody else does. Maybe I'll go first, if you don't mind.
That's all right.
You're welcome to stop sharing your screen if you'd like, or go back to your title. Maybe you can go to your title slide if you want to.
You want me to go? Do I need it? Or?
No, not necessary. Only if you want. So thank you for your presentation. So so as a trauma surgeon, there you kind of provoke multiple questions in my mind. First, just some general questions. When you say level 1, level 2, level 3, what does that signify in Nigeria? So it means very specific things in the US. So in the US, for example, a level 1 trauma center is the center that takes the highest complexity of patients, but has 24-hour trauma surgery in the hospital coverage.
Absolutely.
24 hours neurosurgery coverage, 24 hours orthopedic surgery coverage, 24 hours radiology coverage.
Absolutely, yeah.
And does research and does prevention. A level 2 center has all those clinical services, but doesn't do any research or injury prevention.
Yeah, absolutely.
A level 3 has maybe trauma, but not the other things. And so the grades have to do with what clinical services are available, and then what the expectations are in terms of community engagement, injury prevention, and research. So how is that structured?
Yes.
Area?
Yes, thank you for, because I don't want to, I assume everyone, has a very broad understanding of all these things, and I don't want to be teaching my teachers. So if I must say it that way. So, but thank you for bringing that question up. So, it's not something that is really, really well, laid out in my country. First of all, you'll be surprised that some people don't even use the terminologies but because we know that we want to be able to make comparison as well, and we also want to be able to, follow best practices. We try to designate them as such. But so, National Trauma Center is level 1. And the reason why it's level 1 is very, very similar to what you said. It does have a 24-hour emergency services, right? Apart from that, it does have multiple specialties. So it has a burn unit, it has a reconstructive unit, it has a pediatric unit, it has all this complex anesthesia. It's the resources for essential trauma services are well demarcated and well delineated, right? It has a trauma team, a minimum of 5-member trauma team, So these specifications by the American College of Surgeons and Trauma, is for National Hospital Abuja, which is the only one. It does have that, right? And again, there's research going on, like part of this. Dr. Laomi and his team have been engaged in a couple of trials, clinical trials over the past, years. So that is a level 1 trauma center in that regard. It's consistent with what you have in the US. Maybe there will be differences in terms of the resources because it's a resource limited setting. But to the best of my understanding, National Trauma Center has about 120 bed capacity. And I think that also fits into part of what is being used as the criteria for designating the trauma center. So for level 2 is similar to level 1, but for us, research it's cut across. We Well, I wouldn't know. I can't remember what the committee recommends designate as the research, because research is done almost everywhere, you know. But I guess it will be more of very focused research that you meant, that level 2 won't do research. But I think level 2 can do research or cannot do research. But for our own level 2, which is University of Abuja Teaching Hospital, they are similar to level 1. But the only difference within them is that they don't have, for example, they don't have that 5-member trauma team. It's about 1 or 2, like 2 or 3, between 2 or 3 trauma members that constitutes both the lead surgeon, a fellow, a medical officer who's on standby, something like that. But for, National Trauma Center, which is level 1, it does have, a lead trauma surgeon. It does have representatives from different specialties, so this is what we have, and again, it does also provide 24-hour services, but it does not have all the subspecialties. That's level 2. So level 2 is similar, but it's an incomplete version of level 1. And that is the University of Abuja Teaching Hospital for you. While level 3 is it could be level 3 or level 4 for us. But we chose level 3 because it's a general hospital that is fully supported by the government. So we cannot compare those to, an independent or a primary healthcare center, because usually the government-sponsored centers operate at the secondary level of care. So by that, it's been given a designation of level 3. So they don't have those trauma team. What they have usually is they have a medical officer manning, the hospital, manning the emergency department with at least one, nurse or even a medical officer. So, but 24-hour services, that's what's supposed to be. But sometimes because of the systemic barriers, there's no bed availability, there's strike action, because it's government, like I said, it's government supported. So they won't provide that, they won't provide that. So I think it's pretty similar. I don't know if I answered your question very well.
Thank you. That's helpful. And then one other question before I open it up to other people who might have questions or comments. Why did you decide to use the ISS and the revised triage score? Because really ISS is not meant to be used for patient care. It's really only calculated after you've evaluated the patient and done all the CAT scans. So what is the thought process behind using it in the pre-hospital setting, which is even before hospital-based trauma care, and instead of using something like the South African triage tool, which is actually extensively validated and more easier to use, because you're talking about lay people, police officers with minimal degrees of training using triage tools. So why not use something that is more that may be more established for that purpose?
Yes, so I think this is a very good question too, but it also depends on this decision is not something I made on my own. So it's a team decision, right? So if a South African tool has been used, but again, we also want to be able to use a tool that most people are familiar with or are comfortable with, right? So injury severity score is what is predominantly used in Nigeria. So context matters in any type of intervention we do. So I think the trauma team use more of the injury severity score. So that way they can relate with it. This has been ongoing for years. This is over decades that has been used. So it's one thing to have evidence-based practice. It's also one thing to have the evidence-based practice being adopted or adapted. So even if that evidence-based practice does exist in South Africa, it still does not mean that is the way to go. We have to consider other things. It's a complex decision process. So injury severity score is what the trauma teams in Nigeria are familiar with, what they use. So engaging them in that process, that is what we agree to use, right? So no matter how, we believe it's not as complex as it is. we believe it's not as complex as it is. And that's the reason why we are planning to have a decision tool, a support decision tool, because that way, all they need to do is just to input some of these characteristics and it will be, automatically calculated. But when I also say that they have lay first responder, that does not mean that they don't have, because to take a first aid or basic life support training, you actually require some level of literacy and understanding, you see? Because like I said, we've done the study of knowledge and only 5.7% had good knowledge, but up to, 70% had, fair knowledge. So to some extent, we don't anticipate problem with that when you just want to range something like, okay, this is going to be a mild injury, moderate, severe, critical, and you give it a score of 5, there has been 6 when you're using the abbreviated injury scale. So we don't see that being a problem because, again, like I said, what the trauma team is used to, not us as a researcher, but also those on the field, like those who we're going to be working with, So that's what is obtainable in my country. And perhaps this will be the first opportunity to also assess how good ISS is on the field. So not necessarily to say that I'm discounting or disregarding what is being in South Africa. But again, it's a complex decision process whereby you want to be able to just, respect people's, opinions and contributions and also use what is most obtainable. I'm always careful, or we are always careful about introducing new things. When it comes to research, there's what we call knowledge research gap, research practice gap, or knowledge practice gap, or no-do gap. You can have an evidence-based practice, but to actually put this into practice can take a span of 10 years. Yeah. So, or even 17 or longer. But it's something that also requires some social behavioral change framework. It's not easy for people to change. You can't just ask people to change. Otherwise, you're going to run into trouble. So having people to change to something requires another intervention on its own. So we don't want to disrupt that, and we want consistency. We want short validity and all that. So we don't want to ask people to switch all of a sudden to something that they're not used to, So I think this is the reason why we are using that. I don't know if I answered your question very well.
Thank you. I'll open to other people to see other questions or comments from others. All right, I'll progress to asking some other questions while people are thinking about more questions. Are you planning on studying triage for the adult population or the pediatric population, or both?
Yeah, so thank you for a very, very good question again. Yes, the inclusion criteria is all road trauma patients. So, and the exclusion criteria is to exclude those who discharge against medical advice, those brought in dead, and those who are being transferred from other hospitals. So we want directly transferred patients. So it depends on the size of the sample size. If the sample size is large enough, we can have disaggregated data. We can have age disaggregated data. But we're always careful about that too. When you don't have enough sample size, right? If you keep on disaggregating data, that will also affect the precision of the findings. So this is something that we have on our radar. It's always good to do that. So we will definitely love to do that. But it also depends on the sample size that we're able to have for the time that we are willing to conduct this study. Because again, resources also comes to play. We have planned for a 5 months data collection, right? So we'll be able to make the target for what we want. I don't know if I've answered your question very well.
Okay. Thank you very much. Are there questions from other people?
Yes.
Yes, I think there's some questions in the room. Go ahead. Yes.
So thank you very much for this diverse approach, especially involving the police in trauma. My question is, will the police be having the scripts for filling the questionnaires? Because recall memory can be very dangerous. And the settings where accidents happen, will you be having the research assistants on the ground so that by the end of the day, you can have minimal data with a lot of bias, because sometimes I can feel what you want instead of feeling what the actual state of the patient is. The other thing is about the infrastructure in Nigeria. I don't understand about the ambulancing system, the referral mechanism, and especially the involvement of the police. Involving another unit might be very tricky, because to circulate that information, especially in all those states, how sure are you that they will have the same uniform information to fill in your questionnaire so that it's not biased? Thank you. Those are my questions.
Great question.
Thank you very, very much. I like that question. I like that question. So, first of all, I don't know. I'm being distracted by something. Sorry, I'm being distracted by. Okay. All right. So yeah, first of all, let me bring you to speed about how the data will be collected. The data will be collected in the hospital setting. Actually, it's going to be collected in the hospital setting, not in the pre-hospital setting. So, and it's being collected by, locally resourced persons of medical experience in the emergency departments. And that is one of the reasons why the recruitment is taking is taking some time, because we want to be sure that we have people who have adequate knowledge, who are also motivated to be part of this, right? And to also work out modalities of what the emergency department looks like. Emergency department is a chaotic center. Like, it is chaotic because it can be chaotic, let me put it that way. So again, there's shifts are being run. So when shift happens, how does the data collection continue? So those are the intricate things that we are, ensuring that we are, going to be taken care of. So it's not going to be collected on the field, it's going to be collected in the hospital. And we're going to be using, like I said, it's going to be electronic based. We're using a red cap data collection method on tablet. It's going to be Samsung tablet data collection. So they have all the sites. We have 7 tablets in all sites to be used by these research assistants. So the goal is for them to engage with the trauma patient themselves, if they are able to communicate. If they are not, to engage with their relatives. If the relatives are not the one that brings them to the hospital, to engage with the first responder themselves. So yes, we know that there's going to be recall bias in time, which we know, but the best of our abilities, in a trauma setting, is still the same way we, elicit information from first responders, from relatives. It's still going to be the same way that we're going to elicit information. So, and those information that will be elicited even in the emergency department is what has been used to inform clinical diagnosis, to inform management protocol. So if that's what we're going to be doing, I don't see it's going to be a problem. And that's why we say we're going to be recruiting those who are medically inclined. In fact, to the list, they are likely going to be medical doctors, or at best, health nurses or they have health-related degree, minimum of health-related degree. So because, again, we want to be sure that they are asking the right question. And that's one of the reasons why the training is important. The training is to ensure consistency in what is being asked. If one research assistant is asking one question in this way, another one is asking it in this, we want it to be consistent. And that's why the training is going to be conducted not just once. I've done one training for them, but that's excluding the research assistant. So again, I'll be doing it again with the research assistant and the local PIs themselves. So, and we're going to have like 2 sessions of that, just to be sure that everybody understands what the questionnaire involves. But again, to also, circumvent some of these issues, we use some logic model. We've used some logic model in the red cap. So that way it reduces error. So if you enter a variable, it's automatically calculate this for you. So these are kind of the things that we also emphasize that will probably, reduce, information biases. Again, we don't envisage so much problem in terms of variability across study setting or study site, in the sense that once the training is uniform, I think we are on the good path. And there's going to be continuous monitoring and evaluation. We can monitor the data. We can monitor the data inflow on our back end and see where the problem is there a possibility that some sites are having challenges, and we can account for all those externalities as well. But to do that also requires transparency, communication, interests, motivations, and all that. So that's not a challenge. This is not the first time we are doing something like this. The first study we did, which is the knowledge assessment, was done across 31 sites. We conducted the study across 31 police stations. We used a stratified random sampling. It was done across 31 police stations, which is like a site on its own. And we didn't have any issues. We did have issues. We learned from those issues, but it was implemented well. This is 7 sites. So if you can do 31, we can do 7 sites.
What were some of the lessons you learned from trying to do it across 31 sites? Teach us so that we can learn.
Yeah, I think one of the lessons was because I was part of the system. Then I was still in the police. So, and that's when I realized that the issue of partnership, the issue of trust, transparency is very key. So one of the things we did was to, ensure that we work directly with the divisional police officers, because it was done at the divisional police setting. So we ensured timely communication. Timely communication was sent from the Inspector General of Police, like a signal to all these people. And we made sure we had an informal meeting with all the heads before data collection. So we didn't just go there and say, we want to start collecting data. We made sure we engaged. We had a one-on-one communication to explain what we were doing, what's the benefits, what are their concerns. They were asking us questions. Are we going to give them money? So they have motivations. They have things that are going to motivate them. They have things that are going to. So we were using the opportunity to, be sure and be clear on what we are planning to do, and to, answer all that, our concerns. So those things were helpful when they knew what we were planning to do and how we want to do it. So that way they were able to, they were enthusiastic about it, and they were expecting us the next time. So that was it. Then again, we also used the police resources. All the research assistants were recruited from the police. We did not go outside to look for someone else. So we recruited all research assistants within the police structure. We used the police vehicle as a project vehicle. So this is the transparency, this is the communication, this is the, a community approach, and that way they felt part of the project. They knew there was buy-in, there was ownership, and it was mandated. It was mandated that all police officers should be part of it, because it was a great opportunity. So I think that area is also one area that we're also applying now, not just to rush, not to see it as is a one-time event, because again, when the grant comes in the future, there's still this same site that we're going to go back to, so we've learned that a lot, that we don't want, and because already the system is used to people that just come and just say, we are doing a study, we have us data. That's what is obtainable. That's the narrative. Well, that's not the case. We want to change that narrative. And we also want to leave them with something that they can continue on their own. The Red Cap platform can be used by themselves, even for their own trauma system in the future. So it's a mutually beneficial arrangement. So I think community engagement, if I want to put it in a nutshell, is critical to, conducting research in a setting as complex as my country, Nigeria.
Thank you. Are there other questions? Yeah, go ahead. I think is Dr. Daisy, Dr. Adolph?
Okay. Okay. Thank you very much. I would like to thank Dr. Kehinde for this presentation and very good project ahead. And some of the things you mentioned, which is also very key, it's about knowledge gap, which was like baseline, which showed that there was association with mortality rate for trauma patients. And even one of the PHTC system you mentioned about in-mid, the knowledge was something you really mentioned would help to improve the outcome of the patient with trauma. And some also, I think, if I'm not mistaken, you said some, you don't have emergency medicine patient, you don't have kind of emergency medicine specialist. It's not established in Nigeria. You only deal with patient in emergency department. Trauma care is with the patient in the department. So I would maybe ask if that maybe would be involvement of the government, not only for your project, but are you maybe planning to do kind of recommendation for that establishment of a long-term project for increasing that knowledge, maybe to be involved in the government policy, and if that would be better, it should be really nice to hear about that. Another thing was, my question, it's not far from what my colleague asked. It was you said you're going to use smartphone application based for pre-hospital triage tools. Is that going to be used by health professionals, or how is that going to help you to improve that pre-hospital and outcome? And I just want to hear about the smartphone application, because even if the patient has trauma in a remote area, smartphone is going to help. What about to reach the patient who had trauma in low or in other setting, which maybe a smartphone internet can't really have access? Some comment from your part would really help me to understand. Thank you.
Yes, thank you for the question. I'm not sure what your name is. I'm not sure whether I got that. Your name, please.
Oh, he's muted. It's Dr. Adolph.
Okay, Dr. Adolph. Okay, thank you, Dr. Adolph, for the question. So the first question, if I understand correctly, you were asking about what I said. I said, I talked about emergency medical services. So emergency medical services, the way we say it here is as equivalent to an ambulance service. When we say emergency medical services, we actually mean ambulance services, right? So what I was saying is that Nigeria does not have a functional emergency medical services. And I went on by saying that if a country of 36 states and one capital has just emergency medical services functional in 2 states, and even the 2 states is just suboptimal, it's as good as we don't have a functional. Yeah. So what we rely on is the tier 1, because the emergency medical services is categorized under the tier 2 level of care, right? Pre-hospital trauma care. But what we have is tier 1, and the tier 1 includes the lay people, which includes the police, the federal road safety, and even the bystander. So that is what we have. That is the reality of things. You also mentioned something that is very, very important, which I'm not sure I talked about, but I think I can address it because it's a relationship. You are correct. At the moment, there is no emergency medicine specialist training in the country. There's none. I did my residency in community medicine. We don't have any in that. Efforts are ongoing to develop that, but the progress, the depth of the progress, the breadth of the progress, I'm not aware of at the moment. But it seems to be going very slow because this is something that has been on discussion since year 2016, on top level discussion, high level discussion. But we're in 2023 and it hasn't taken effect yet. So if you remember, I showed a slide about unmet needs. Where I talked about the agent, the host, and the environment. Under the environment, we have the legislation, the funds, the training, the policies. So if this is a complex problem, complex problems often require complex solutions, right? But even no matter how complex the solutions are, there are still ways, there are still trade-offs. There are trade-offs as to how one can, maximize impact. So that leads me to the issue of smartphones. So to round off what you said about the emergency medicine and every other thing, advocacy efforts are ongoing, or it can be better. And this is part of the thing that we're also considering in the future to have as part of our research, objective. They can actually go concurrently. They can actually go concurrently. So, but to the issue of the smartphone, well, maybe I should have said mobile phone or mobile device enabled, maybe. But the issue is, we know from the field, evidence from the field suggests that there is high proliferation of smartphones among the police officers, right? Not just the police officers, even there are statistics that shows that Nigeria or Africa, for example, Africa has mobile device or smartphone device use penetration rate of about 48% as at 2021. The smartphone penetration rate in Africa is up to 48%, right? So, but again, I'm speaking from my own experience, field experience as well. The field experience shows that the availability of smartphones among the police officers, which I said they're going to actually be the pilot, study population. Again, because this is the population that we have been working with for a long. This is the population that also, also deliver 50% of respiratory trauma care to road traffic victims. Again, because they have the large number, and they also have the sort of support. So police is going to be the pilot study population. Smartphone availability demonstrates some visibility of the future intervention. But again, there's also a need to think about what about those in the rural areas. And that's why I said maybe the best would have been to say a mobile device. But because I'm not sure of how we're able to use the mobile device, I know that technologies such as web scraping technology, USSD code, all these things, our digital infrastructure can play a role, But the smartphone application is an application that we are emphasizing that is going to make use of geospatial data. It's going to make use of geospatial data in terms of bed availability, because we want to be able to maximize that tool. Even if a first responder is able to say this patient has high severity of injury and needs to go to social trauma center, and the trauma center has been identified by the tool, we should have an up-to-date information that there's bed availability in that trauma center. Because if there's none, there's no point going there. You understand what I'm saying, sir? There's no point going to that center. Then that same app should be program to reroute to the next available, designated center that has the available bed. So I'm not sure how a mobile device, not a smartphone device, will be able to do this. I'm not sure. This is not my field. Although I just recently completed a GIS training course with Professor Wang Nan in your institution, but it was just basic. But these are food for thought, so that we can address the issue of equity, because what you raise is an issue of equity. How do we make it equitable? But the good news is that the penetration rate is increasing, and it has been projected to further increase by up to 48% over the next 5 years. So, there's a future intervention. So the future intervention can also meet the future progress of digital technology. So this is the way we think about it.
Great.
So,
well, thank you very much, Dr. Kehinde. Okay, have a good day. Okay, bye-bye.
And you too. Bye-bye.